invite Dr. Meena Kharat, and she is going to speak to us upon the contact lenses and orthokeratology. Dr. Meena.
Good morning, everyone. I thank Dr. Namrata and AIOC team for inviting me here today, and also Dr. Lahani, Dr. Shukla, and Jyoti ma'am. Jyoti ma'am, you have already spoken about this spectacle, so I will not go into that details. We already know it is epidemic, almost pandemic now. Myopia is a problem. We know when the parent are myopic, there's twofold risk, and both parents myopic, obviously there's a fivefold risk. Asian descent will have more risk, and if you have a high-fat diet, a sedentary lifestyle, lack of outdoor play, and more screen time, patients are more prone to myopia progression. So myopia and orthokeratology have already been studied by many countries, and there are many papers which suggest that orthokeratology is the one of the mechanism and remedy for myopia control. Okay, so again there are so many papers about it. So myopia we already know, so I won't go into more details why it is so important problem these days. And there are many strategies. We have pharmacological, optical, spectacle, contact lenses, and obviously the lifestyle. So just normal, whatever GP contact lenses we give, they are not suitable remedy for it, and there is no evidence that it corrects it. But multifocal soft contact lenses are used. The current multifocal contact lenses that we have, they are usually for presbyopic patient. What we use, they are center near designs. They are not suitable for myopia progression control. What we need is a center distance design. So the central is distance, and then the periphery is a ring of a near, and then again center, and again distant and near. So those lenses are important. So MySight is the only lens currently by FDA which they have said is important for myopia progression. Another one is a SEED, which is a EDOF lens. And currently there is an LV Prasad, there is a study going on where they are using the 2 weekly disposable SEED lenses, which are also giving us good results with center distance design of soft multifocals. Okay. So we already know that when we give normal glasses, it will cause the peripheral hyperopic defocus, and all these lenses, what we have to give is cause the peripheral myopic defocus, so that it will correct, that it will ask the, it will not give the signal for the eyeball to grow. That is the principle behind all this contact lens correction. So corneal reshaping of contact lenses is basically the orthokeratology is very important, and that is in studies they have shown that about 52% reduction in axial elongation has been seen. So ortho means straight, keratis cornea, and ology is orthokeratology, basically it's a knowledge. So this is basically technique developed by a person who have seen that it causes a improved centration. Once the centration is good, then it causes the flattening of the cornea in the center, and in the periphery, in the mid periphery, it causes the hyperopic defocus. So central cornea is flattened by about 0.3 to 0.5 mm. Then the flattest cape. Then it depends on the corneal sill, obviously, and if the sill is too much, then we don't use orthokeratology, or we'll have to use special lenses for that. Okay. Then the steep periphery will aid in the tear exchange and centration, and larger total diameter will be required for the good centration. So this is the effect. These lenses are reverse geometry lenses. So in the center they are flattened, and in mid periphery they are steepened, so that they cause this treatment zone which is in the center. Now how much should be the treatment zone, that will again depend on each patient and the myopia. So we already know how much is the epithelium, Bowman stroma. So this treatment is basically only for the epithelium. We are not playing with stroma or descendants or endothelium. So anything goes beyond epithelium, then this is not the treatment that we want to do. So how much area that we are going to flatten? So that is the change in the corneal sagittal height, which will be equal to the treatment zone diameter square to the desired dioptric change. So if we want 1 diopter effect over a 6 millimeter zone, then we have to flatten 12 micron of corneal tissue. So that will be redistributed. So it is something like when you press on something, it is going to bulge somewhere, right? So you are not going to take that part out like in LASIK. It's going to be just pressed. So it's going to bulge out. So we have to give that, the reverse zone in that so that they are steeper and the tissue will be redistributed in that area. So this is how it looks. So you're pressing in the center and in the periphery, you can see the tissue is like redistributed over there. So that will cause the hyperopic defocus. So on the topography, you can see the central part will be flattened and mid-periphery will be steepened. Now this has to be in the pupillary area, within the pupillary area. If this area, the steepened area falls outside the pupillary area, then it is not for myopia progression. Then it is for myopia, it's a management. Like if a person like a 20-year-old or a 25-year-old do not want to wear glasses, we can still give him orthokeratology, but that is not, this zone will be bigger. So we don't have to keep this steepened zone within the pupillary area. We will only keep it in pupillary area when we are talking about the myopia progression control. So if you take before and after and we take the difference map, this is how we will see it. So not all patients are suitable for ortho-K. Like older patients who are wearing contact lenses for longer time, the cornea which are less likely to respond well, patients who have unrealistic expectations, against the rule astigmatism, and low sphere power with high cylinder, and limbus to limbus astigmatism, all these patients are not suitable for ortho-K. So corneal topographer is must. You have to measure the axial length, precision fitting has to be there, and significant rigid contact lens fitting experience has to be there. And you have a large set of special OK lenses, which is again expensive, you have to invest into. Nowadays, we can just give the K readings to the laboratory and the treatment, how much myopia we want to control, we tell them. And we don't need any fitting set. And the laboratory will send you the lenses. Sometimes we just do it on the topographical data, and contact lens fitting softwares are available. We can just do a trial contact lens fitting based on that, ordered directly from the laboratory. Or you can have the fitting set where you have up to 100 to 140 contact lenses with you and you try different contact lenses on your patient. So this is the ideal fluorescent pattern you see with central flattening and mid-peripheral pooling of the fluorescent. The same diagram schematically. So ideal fitting pattern should be 3 to 4.5 millimeter of central corneal bearing, wide, deep tear reservoir around the central bearing zone, good lateral centration, okay, so pupil coverage, good vision. So patient has to be, when he is waking up in the morning, there is no need to wear glasses or contact lenses throughout the day. So if you just say the treatment zone, we want to keep the same, say about 20 micron. Then the treatment diameter, the zone diameter, if you just compare that, if you have the bigger diameter, then you are just reducing only 1.75 diopter. But if you reduce the treatment zone diopter, you can correct up to -6 diopter. And here again same thing, if you want a reduction of -3, then if you keep the treatment zone only 3 millimeter, then you have to displace only 9 micron. Where if your treatment zone is bigger, say 7 millimeters, then you have to displace more, about 49 microns. So you have to choose accordingly. The same one, if you want expected change of 1 diopter in a smaller treatment zone, you have to depress a lesser of corneal tissue. So this is an older study which they said that maximum up to -4 are very well treated by ortho-K. and you have to review them. I mean, first night when they wake up in the morning after all night wear, you have to see them first thing in the morning along with the lenses on. Okay, and then you see whether it is what is their vision, what is slit lamp examination, how well they are fitting, how then you do the retinoscopy and measure the topography. Follow-up visits are also important. So first day following, then you do all the studies that you have done, and then you have to do follow-up visit in 7 to 10 days, allows full treatment to take effect, then repeat assessment, and if it's not acceptable, then you have to modify the design. Again, you have to redo the same thing what you have done. So you have to, once you have corrected the myopia, whatever desired, then you give them the retainer contact lenses. Again, care and requirement is very important. You have follow-up visits are very important, weekly, monthly, 3 monthly, 6 monthly, and 6 monthly thereafter.
We'll have to sum up, Dr.
Yeah,
Meena.
sure. And basically take care of the contact lenses as well, all the different. Now, this is just to give you advantage of orthokeratology over refractive surgery, because refractive surgery you cannot do it in children, and ortho you can do it. Reversible, it is a reversible process. So when you stop wearing contact lenses, it will come back to where you started. So it may slow the myopia progression. And disadvantages, it's not a permanent solution. So when you stop it, you come back to where you started, basically. So everything you have to remember is it needs attention definitely, but you do not scare your patients. Nowadays, in the myopia, so much we talk, sometimes patients and parents are so scared and they Google it on and they said, okay, I'm going to go blind. I mean, I have seen 2-3 patients who have come to me with -8 and now they are saying, will I go blind? This thing will happen to me. So you have to counsel that also. Don't scare them away. So choose your patients widely and give them best possible solution. Lifestyle modifications are important. Atropine, of course, spectacles, soft contact lenses, ortho, choice is yours. So tailor it as per your patient's need. That's all I would say. Okay, thank you very much.
Right. Thank you very much. I think it was very good thing, Meena. Questions from the audience? Yes.
Actually, I had a personal experience. One of my nieces was wearing these ortho-K lenses.
Okay.
So morning, absolutely fine, moving around and everything. But by evening, she was just making a pinhole of the eyes. And by late night, around 10 to 11 p.m., she was almost, totally dependent because she was not having her spectacles also, and with ortho-K lenses, after evening, it was very difficult for her to manage the thing. So how to go about it?
See, what happens is ortho-K is actually only give you effect up to say 8 hours. 6 to 8 hours, depending on the prescription, age of the patient, how much molding you have done. Okay? So you have to give them backup glasses. So towards the end of the day, they will not probably, suppose she is -3. She will not require full -3. She may require -2 or -1. You will have to do that refraction in the evening and see what she wants, what is her prescription after say 8 hours. So there has to be backup spectacle in that case.
It's not actually that you are actually keeping the patient away from glasses. You have to keep them with the glasses.
Yeah. So, but 8 hours, I would say, it's definitely, if they're working hours, they can, yeah. But evening, yes, they will have to.
Yeah, see, this is a big problem with ortho-K lenses, because you're wearing it for night, and you remove it in the morning, and you say, the company says the patient is, has good 6/6 vision for whole day, but that is not the case. See, as you are saying, so that's a big number one. Number two, you're removing these lenses in the day. That is the time when the people are actually working. You see, where is the effect of myopia is gone. When you are sleeping, there's no. So now that the problem is that they are saying that it is more for management of myopia rather than controlling the progression of myopia. So when you give these lenses to a patient, you have to make them clear, counsel them correctly that we are not guaranteeing you that we will control myopia. And the other problem, what you said, is there.
Yeah. Atropine plus orthokeratology is better solution.
Yeah,
Just
the cost is also.
Yes.
Combination.
Any other
Definitely
questions?
costly.
Any other question? Okay.
Just 5 minutes more, so you can have anything.
I think the, yes, yes, yes.
Sure, sure.
I would like to ask a question to Dr. Suma. This atropine eye drops that we use, is it purely for myopic, spectral power, or it can be given for astigmatism?
In that, Suma,
You can
speak in the speaker.
You have a हाथ वाला नहीं है क्या?
Yes, yes.
A good point you made. Because most of the patients, sometimes I'm seeing people even when there is astigmatism number, they are prescribing atropine eye drops. It does not work for astigmatism. It is mainly trying to halt the progression by working on the vision. So it is said to prevent anti-inflammation. Yeah, if there is a progression in myopia and along with it there is astigmatism, yes. But parents do ask that whether the astigmatism, because you give LDA suppose, next time the child presenting with the increase in symptomatic power, then they ask how much of the and then you have to tell them that it does not work on this symptomatic power. So basically they are trying to halt the progression of myopia only, not only symptoms.
You say how much astigmatism do you expect? 5, 6, 7? No. See, normally the astigmatism doesn't go more than 3 or 4 in any case, More than 6 it goes, then you have to think of keratoconus or something else. So for that, just one astigmatism, whether it is meridional or whether it is, the normal one, you don't give atropine. It's not going to work for that because that is a corneal astigmatism. See, because that is due to cornea, not axial length. So.
But I think one caution is that like we have started doing is that whenever when they are progressing, the myopia also is progressing, we are getting a pentacam done because you can have, there are reviews, there are papers which are saying that higher the myopia the patients can have, the progressing is much more, they can also have keratoconus. So it is important for us to check that also.
Yeah, that of course, it's very rare that you have both together, the corneal myopia as well as, the axial myopia. Normally the genetic what we have is for axial myopia. Corneal is very limited, but rarely it can, combine together. For that, then you have to look for the axial myopia progressing. Any question?
One more point I want to say that when you're talking about tapering of myopia, yeah, we say it as a standard 2 years, but when you're deciding to do it, ensure that at least for about 6 to 8 months, your axial length is not progressed, your refractive error remains stable, and only. Also remember in children, the puberty is a time when it can shoot up, there's a growth spurt. So you confirm with the parents that yes, the patient has attained the puberty, and boys it comes later. So many a times, unlike the the other Asian studies where people have spoken about till 6 to 12 years, in Indian population we have had to give up to 14 and 16 years. So watch these things. So every time you decide to take off your atropine, be sure that is off, the refractive error is not changed, your axial length is stable, it's not increased, and a patient has attained the puberty. And the lifestyle also is like he's taking those breaks, he's doing it, so that you know that when you're taking it off, it's not going to come back as a rebound. So that is what you have to watch. So it's like individualized. You cannot say like, everybody, but try to understand each patient, each family. Like you may have a family where both parents are high myopes, brother is high myope, and this child is already progressing. He's a voracious reader. So there are a lot of things that come in. He doesn't go out to play. So there are a lot of things. So you have to look at the whole picture as a whole and then decide what to do with each of them.
I think, thank you very